გამარჯობა. მე ვარ ლიკა ჭყონია, ქართულ-ამერიკული რეპროდუქციული კლინიკა რეპროარტის დამფუძნებელი და დირექტორი. დღეიდან ჩვენ შემოგთავაზებთ პოდკასტების სერიას საუბრები ვიტრო განაყოფიერებაზე. პირველი სერია იქნება დღეს. ჩვენი პირველი სტუმარი არის დევიდ მაკკალა, რომელიც არის ჩვენი ამერიკელი კოლეგა და ჩვენი კლინიკური სამეცნიერო ნაწილის ხელმძღვანელი. დღევანდელი თემა არის ვიტრო განაყოფიერება და სამეცნიერო კვლევები. არის თუ არა ცოდნა, დიდი ძალა. ამ თემაზე დღეს ალბათ ძალიან საინტერესო საუბარი გვექნება დოქტორ დევიდ მაკკალასთან. Hello, Dr. Makaala.
Hello, Lika.
Okay, so I wanted to say that Dr. Makaala is one of my mentors, and when I started IVF in the United States, I was lucky because first I went to Norfolk, Virginia, Jones Institute for Reproductive Medicine, which is first institution in the United States who did IVF. And there are lots of interesting stories about how first IVF was done in the United States, but we will talk about that later. And afterwards, I moved to New York to offices of fertility and reproductive medicine, and Dr. Makaala was my boss. And I learned so many things from him, and I was really lucky to be first with Susie Lansendorf and then with Dr. Makaala. And now we are working together in Georgia as well. Nice. So I hope that we will continue that for a long time.
Oh yes, so do I. And I might add that now the tables have changed. And now I work with Lika, and I'm learning from Lika. So
thank you.
It's important to realize that.
Okay. We can start from a short history of IVF in the US and Georgia. And I would ask you to give us a short history of IVF in the US.
Shortly after Louise Brown was born in the United Kingdom, IVF, the United States felt like they had to compete. And the Jones Institute was opened, and there were a couple other places that were early centers that began to do IVF. One was in Houston, Texas. It was run by a fellow named Martin Quigley, and the lab director was Don Wolfe. And they had a trainee, physician trainee, Cecilia Schmidt-Sarosi. There was a third program in Los Angeles that was run by Richard Mars. IVF started taking off, and it grew and grew in the United States. People moved, people left where they were, opened up new places, and IVF quickly started growing throughout the country. Don Wolfe moved to Oregon on the west coast of the United States, and a few years later, I went to work with him to learn the laboratory for in vitro fertilization. I had previously worked with him when he was at the University of Pennsylvania before he went to work with Martin Quigley, when I was a graduate student, and I was learning to do in vitro fertilization with rabbits and mice and hamsters. Then after I had finished getting my PhD and had done some postdoctoral work, I decided it was time to get involved with human IVF, and I called Don, and he invited me to come out and work with him. After a year, I moved to New York, and in New York, I worked with several people, but eventually with Cecilia Schmidt-Sarosi, yes, who had trained with Don and Martin Quigley in Houston. And we needed to hire people to work in the lab, and one of our first hires was Lika. And Lika had worked at the Jones Institute, so it was a melding of the Jones Institute and the Houston program, and then eventually the Oregon program. And we created the Offices for Fertility and Reproductive Medicine, OFRM. in Manhattan and had great success during the time when we were transitioning from doing day 2 and day 3 embryo transfers to doing day 5 embryo transfers of blastocysts, which was a major advancement in the field. Just before we got together, we had started doing intracytoplasmic sperm injection, so we could inject sperm into eggs to get fertilization, which dealt with a lot of the problems with sperm, with male factor infertility. And then the culture to day 5 led to a better ability to select embryos for transfer. Lika and I worked together, and then Lika moved to Georgia. And it was a big loss for our program. And then I moved to New Jersey and worked in New Jersey for a while. But in 2006, I came here and started working again with Lika in Tbilisi. And since then, we've been working together.
Yes.
Yes.
It's been a long time, right?
Not a long time. It's been many years, but it has not felt like a long time.
Okay, it's many years, yeah. All right. Well, I can add some few details. We started in OFRM. I started in OFRM. It was 1995, I think. So can you imagine? First ICSI success was in 1991. We were like in the beginning of everything. We started blastocyst freezing when it was lots of programs were not successful in that, and it was really amazing how well we've done that whole thing. And I was teaching ICSI in 1990, beginning of 1994, ICSI and biopsy in Norfolk. So it feels that we are in that small bite of people who just started this whole thing in the world.
Yes, it was a very exciting time in
Yes.
IVF. Many programs had focused on hiring people who had a research background.
Right.
Because the field was in its infancy and a lot of things had to be improved. And they thought that hiring research people would be the best way to actually do some experimentation and get things to work better. I remember when I first started out in Oregon, we were happy that we were getting 20 to 25%
fertilization rate?
Well, pregnancy rate.
Pregnancy
Pregnancy rate with our patients. And we were transferring 3, 4, 5 embryos.
Yeah, that was.
And as time progressed, we lowered the number of embryos we would transfer, and the pregnancy rates were going up. But real advances were made when we had ICSI and when we started doing pre-implantation genetic diagnosis.
Yes, that's true. It was really a huge breakthrough. Yeah. And, well, when I came back here to Georgia, and we had hard time in Georgia because of difficult 90s, and information was not flowing as well as it was in the whole world. So we had to work hard to get the information. I brought this knowledge from United States. I did maximum what I could to change philosophy of working in Georgia. And then that's why we created ReproArt. It was easier to have all this knowledge and ethics and philosophy transferred to ReproArt and to start from the beginning in the way how I wanted to have program done. So I'm really happy with that. And what I wanted to tell you, when I came here, actually embryos were not freezing. There was no such a knowledge here. And actually, I started again with blastocysts to freeze blastocysts, and we got very good results immediately. So it was excellent. And of course, ICSI, our first ICSI baby, was born after I came here. So I transferred all the knowledge you gave me to Georgia.
That we learned together.
Okay.
Yes.
Okay. And now I want to ask you about the research. What do you think?
Well, I think that research, as I mentioned earlier, has been very important for in vitro fertilization, the field. Interestingly enough, many of the advancements for IVF happened on the clinical side prior to the time when you and I met. Right. The drugs became available, which was a big deal. The gonadotropins, the gonadotropin-releasing hormone agonists, those the physicians had already started working with, and of course they have increased their knowledge and how to use them since then. But around the time that you and I met is when the laboratory became very clear that what happened in the laboratory was really where all the advances were happening. Okay. ICSI. Half the patients wouldn't get fertilization.
Yes.
Because if the sperm weren't any good, you couldn't get them to go into the eggs.
I remember that nightmare.
Yeah. And every time we did an IVF, the next morning we would come in to see if there was fertilization, and oftentimes I had trouble sleeping at night because we didn't know if we were going to have any fertilization the next day. And then the patients would find out that their hopes were totally gone. But with ICSI, that problem, for the most part, stopped happening. So we started getting fertilized eggs for everyone. And then it was just a matter of getting them to develop. Right. And along came new methods for culturing embryos so that we were able to culture to day 5. And along came other strange things like getting oocytes from a different woman. So we could use donor eggs. Right. Donor sperm was already out there because sperm had been frozen for many years. But using donor egg revolutionized a lot of things for many patients. It also meant that we could kind of learn how to deal with a woman who not only didn't have eggs, but may have had eggs that just didn't go anywhere. There were some times that their eggs just didn't work well. Culturing to day 5 meant that the longer you culture an embryo, the more you can tell whether it's progressing normally or not. The day after you add sperm, they have 2 pronuclei. It's one cell. All of them look pretty much the same. If you wait a day, they are 2 or 4 cells. Another day, they're 8 cells. On day 4, they start compacting. Day 5, they start getting a little fluid-filled space called a blastocele, and they start expanding. And it doesn't happen for all of the embryos. Each step of the way, some of the embryos kind of fall by the wayside. And when we went to day 5, we started being able to select those few embryos that really looked like they had some potential. So we were able to select those, and as we selected those, we could select fewer embryos to transfer than the 4 or 5 we were doing previously on day 2. And we could have the same sort of success by transferring 2 or 3, maybe, okay? And then a few years later, we learned that we could take a few of the cells from the blastocyst and do genetic testing on them. And we found that a very large proportion of the embryos from patients who were a little bit older, 35 to 40 years old, many of those embryos didn't have the correct number of chromosomes that all of us have, okay? We have 46 chromosomes, 2 each of those numbered 1 to 22, and then either an X and a Y or 2 X's. And we could look at how many chromosomes were present and find out that a large proportion of those embryos didn't have the right numbers. Those embryos, it turns out, do not do well. Yeah. They may implant. Many of them won't implant, but if they do implant, they generally lead to miscarriage. So a lot of the miscarriages went away when we started doing this testing. And again, since we were using this as a screening thing to determine which embryos that were the most likely to work, we could reduce the number of embryos we transferred, put back perhaps only one embryo. And by putting back one embryo, we could still maintain high pregnancy rates and high live birth rates, but by only transferring one, we got rid of another problem: multiple pregnancy. Multiple pregnancy isn't the wonderful thing that a lot of people think. It tends to lead to premature deliveries. There are lots of things that happen along with premature delivery that aren't good outcomes for the baby. So it solved another problem. And it was all stuff using laboratory techniques, either in our lab or in a genetics lab that we would send the biopsies to be able to do the analysis. So that was another wonderful progression of the field. And as I said, it's in the laboratory. Leek and I work in the laboratory. So it was really wonderful to have those things at our disposal, and we were able to eventually bring those here to Georgia as well, and transfer the success to the Georgian patients.
Yes. I remember how you were doing statistics for every step what we were doing in the lab or the clinicians were doing. And I think that this is a way to success, because then you know what's going on well and what has to be improved. Some people don't understand the meaning of the statistics in the clinic. So please,
yes,
can you comment on that?
I'm kind of a statistics nerd.
Yes.
Yes. And statistics these days are very much the basis by which most research is done. So you can do an experiment where you compare two different techniques and see which one works better. Both may work, but you want the one that works better.
Right.
And generally, in order to determine whether it's really better or just kind of looks better, we do statistics. So we can make comparisons and determine whether there is a statistically significant difference between the two techniques. Now, that leads into other things where we have to control our experiments in ways so that we can make valid comparisons from which we can conclude whether something is statistically significant or not. And it's important when we look at research, we look at published papers, that we understand how the research was conducted. A lot of people just read the abstract, the beginning of the paper, okay? And in the beginning, they'll say, oh, we found a significant difference between this and this. But if you don't understand the methods that were used to get that difference, then you don't really understand how well you can apply that difference to your own practice. For example, we did a lot of experiments. We wanted to compare results between patients who are young. Technique 1 versus technique 2 in young patients. If you find something that's significantly different, you publish the paper. The abstract will say there's a difference between the two techniques. But it may only apply to the young patients that were used in the study. And if you don't read the paper and understand all the methodology used, then you don't really know whether it applies to everyone or it's just to a select subset of patients. So you have to be careful, and a lot of people don't necessarily read the paper carefully enough to know how to apply the generalized outcome from the research to their own practice. So it's very important that you read the entire paper.
Not the abstract.
Not just the abstract, but the whole paper, especially the methods. And then you look at how they implemented the methods within the results to see if it will apply to the situation that you want to apply it to.
Yeah, this is really something we have to learn, and everybody has to understand that. And
now, I think we tend to believe that scientists understand science. You don't have to be a scientist to interpret a paper.
Right, that's true.
But even not all scientists will read the whole paper.
Yeah, I know. Yeah, that
so
happens.
The important thing is that you have to really look at the results as they were obtained, with the results that were obtained and the methodology that was used to get them. Not all scientists look at it that way, but anybody can read the whole paper and smart people can figure it out. You don't have to be trained as a scientist, but scientists tend to be trained to read the paper.
Yes, I know how they trained. I know from SOPO how in United States science students are trained to understand the paper. So SOPO is my daughter, just to tell the audience. Okay, you know what? The question came out like that. What is your most... what work of yours you remember most? I mean, what you think, what kind of work which you've done make big difference for the practice in any practice where you worked?
I think probably the biggest effect I had was in New Jersey. When I first arrived in New Jersey, the success had plummeted before I arrived. They were getting around a 10 to 15% pregnancy rate and had people come in to talk with them about what they were doing. And I came in and things in the lab were going pretty well. But I analyzed what the physicians were doing. And the physicians were actually trying to get too many eggs. Mm-hmm. And so they were making the follicles get too big. And by making the follicles get too big, what happened was they were probably affecting the uterine environment, so it was not really ideal for implantation. They had nice embryos, but when they put the embryos in, they didn't implant. So I did the analysis and I said, hey, you have to aim for this size follicles. When they did that, in a week, they went from, in young patients, they went from 15% pregnancy rate to 50% pregnancy rate. So that was probably what I think was the most marked change I've ever seen from anything I've contributed to an IVF program. Other than that, the everyday making sure everything is in control, daily checking of every instrument, daily checking of room temperature, incubator temperatures, all these things to make sure that you have a solid lab that is always the same, so that if something happens, you know it's either because of the patient or because of one of the personnel in your lab is doing something differently,
right? Then
you can figure it out. But if you don't have any control in the lab, you don't have any control over anything. So that was an important thing, but we always did that in my lab. So it didn't seem like a new addition anywhere. Yeah.
Well, I have this kind of question. How they react, the physicians, when you told them that it was their fault?
Well, for one, I tried to choose my words carefully.
Of course, you would not say that it's their fault. I understand that, but still, the idea.
It looks to me like if we will use smaller follicles, we will do better. And they were so desperate.
So they believed it.
They were so desperate to have their program work because everybody they knew around was doing better. Uh-huh. They were willing to try anything, and when they tried it, it worked. And I remember that I think I went to the ASRM meeting, the American Society for Reproductive Medicine, the big national organization for IVF clinics in the United States. I went to that meeting right the same week when they made the change and got calls that, oh, everybody's getting pregnant now. And of course, I was very happy. I was very happy. It was nice.
Great. Yes.
That was something that
you did.
But as far as things that really made a difference in the field, ICSI, day 5 transfer,
PGT.
Which involved developments by other people who had changed the media,
yes.
had developed different kinds of medium for us to use. And then the implementation of pre-implantation genetic testing for aneuploidy is the biggest thing, where now we're getting 72% of our patients to become pregnant when we transfer one embryo. 62% deliver a live baby. That's a long way from the 15 to 20% that we were getting when I first started out in Oregon.
Yes.
Yeah.
Well, there's a big change, of course, and how many babies are born because of these developments. It's just amazing, right?
It is.
And then healthy babies.
Yes.
Mostly. This
That's
is
right.
the very important
Yes.
thing to say, of course.
This doesn't even, we're not even discussing the use of pre-implantation genetic diagnosis
Yes.
to avoid genetic disease.
Genetic diseases which are in the families. So,
Yeah.
Yeah. And do you think that awareness of patients in United States helps physicians to treat them?
Physicians, well, the patients, when they present to a clinic, or at least the clinics I've been involved with, oftentimes come in and they come to our clinic for specific kinds of treatment. They come in thinking, I need to have PGTA.
They already know.
They already think they know that.
Okay.
They already know that, we're going to need ICSI. We come into you because you have the best success with ICSI or something like that. And they don't really know what's wrong with them. It's nice to be able to diagnose the patients and know what it is that's really seems to be the problem, why they're not getting pregnant. Interestingly enough, whatever's wrong with them, IVF is usually the treatment.
Right. Yeah, that's true.
But it's nice to know if it seems to be the sperm. If it's the sperm, we definitely need to use ICSI, this intracytoplasmic sperm injection. But in the place where I've most recently been working, at NYU, New York University, we don't use as much ICSI as a lot of places. We actually have a higher number of embryos created without ICSI than we get from patients who use ICSI. It's probably for some subtle reasons that don't really matter, but I think it's important to know that if you don't need to use a technique, maybe you shouldn't use it.
Yes, but there is a fear in the world that it's not only in Georgia or in many, many countries that as long as patients are paying out of pocket in the countries where it's not insured, then they want to guarantee the fertilization with ICSI. So, I mean, why it's done so many standard inseminations, and where is the cutoff when they do ICSI and?
Yeah. I mentioned this earlier, that when we did standard insemination in the early days, we would have trouble sleeping at night.
Right. I remember that.
And when we started using ICSI, we didn't have that problem. It was a wonderful opportunity for us to feel like we were doing something that was good. And it certainly resulted in a lot fewer of the patients having no eggs fertilized. So that was a good thing. But there's always the fear that more manipulation
you
may
can
be a
damage.
problem.
Right.
So that's why why at NYU, they kind of scaled back and did less and seemed to have a pretty good run with, so actually now with the patients who get standard insemination, we have about the same rate of failed fertilization, no eggs fertilized, as we do with ICSI, which is very small. Around 1% of the patients have no fertilization. Now the cutoffs.
Yes.
The cutoffs are based on years and years and years of looking at sperm. Okay. And it used to be that we would do a semen analysis, and we would, if the semen analysis parameters, which involve the concentration of sperm, which we call the count, the motility of the sperm, what percentage of the sperm are swimming, how rapidly they're swimming, and then the morphology, which is a newer technique is the strict morphology developed by Thinis Kruger in South Africa. Those have been used to analyze the sperm. And if it looks like the sperm count is really low, then a lot of places will do ICSI. At NYU, we don't do that. If they're not motile at all, they're going to need ICSI. But if there's some swimming, we can harvest the ones that are swimming, and they may work. If the morphology is poor, the funny thing about the morphology is the cutoff typically is when 4% of the sperm look normal. 96% don't. And it's really hard to have a lot worse than 4%. The average is probably around 6 or 7%. So having a cutoff at 4% includes an awful lot of patients. And at NYU, they just decided it isn't that predictive. So they would do standard insemination regardless of the morphology in many cases, unless the sperm don't have an acrosome. That's part of the head that actually is involved in getting through the cells that surround the egg and the zona pellucida, a glycoprotein coat that surrounds the egg. So if it doesn't have that particular organelle, or if none of the sperm have it, then they're not going to get into the egg. So in cases where it's extremely severe, we go ahead and do ICSI. But the main thing that we use is actually looking at how many of the sperm are harvested after we have prepared them. And we wait until the time when the insemination is about to occur. We look at them again, and if the motility has crashed, has gone way down from the time when we originally harvested the sperm, then those are ones that we tend to do ICSI with. And by doing that, we decrease the number of cases of standard insemination that have failed fertilization.
And how long you wait for these?
We usually do the retrievals between 9 o'clock in the morning and noon. The inseminations usually happen between 3 and 5 in the afternoon. So the sperm are generally prepared around the time that is right after the oocyte retrieval.
So it's 2 or 3 hours?
It's 2 or 3 hours, yeah.
Okay.
Yeah.
Wow, that's interesting, really. And I know these beautiful results of yours, and the whole world is just discussing that, and they are just proving it that ICSI has to be done because of that we don't want to have failed fertilization. So everybody fears that.
Oh, and yes, and even at NYU now, as they get busier and busier, the idea of having to change our minds at 4 o'clock in the afternoon.
Yeah, it's a difficult
real,
yeah.
Well, it makes us unhappy when we've got 15 retrievals and all of a sudden we go from, we only needed to do ICSI on 3 of the 15 to now we have to do ICSI on
10 of the
10 of them is really it's a stressor.
Of course.
Yes, and so
how many equipments do you have for ICSI?
There are 4 or 5 setups.
5 sometimes. It's still,
And we have
2 for each microscope.
Routinely, we have around 10 embryologists per day. But those setups are also used for biopsy. So
then it's a kind of,
So it's not just for ICSI.
Same time.
Well,
almost the same time.
A lot of the biopsies earlier in the day. But
you don't know. It can be afterwards too. Well, and in Georgia, lots of patients are aware of what they want to do, but the problem here, what we found out, is that they are kind of shy to ask lots of questions to physicians. I don't know, it's the same in the United States, but I have my experience in the United States when I did C-section. Amniocentesis. I met first the physician, then the patient coordinator, then the head of the genetics lab. So everybody explained same thing, actually. And eventually I got to that point that I was able to make a decision. So this is what we did here in ReproArt. We have a physician, we have patient coordinator, we have a nurse, and we have other person who are like lawyers who are working with them on the contracts. And but still we heard the stories that patients don't really understand completely what we are doing with them. So this is kind of a problem, and they are getting upset. They have high hopes. And when you tell them that it's not 100% and even not maybe in some cases 50%, they really don't understand that. So it is getting very hard to give them real perspectives, what they have to expect.
I think that one of the places where counseling has been very important for the American patients is with the use of PGTA. Mm-hmm. Because the number of embryos you have that will be transferable, or at least would be selected first for transfer, gets smaller and smaller the older the woman is who's having the procedure done. So it's not unusual for a patient to have a retrieval if she's 40 years old, where number one, she has a smaller number of eggs to begin with, and then a small number of those are fertilized, and a small number actually make it to the stage where we can biopsy, and then perhaps none will have all the chromosomes in the right proportion. So it's important that they be counseled that, well, at your age, there's a high likelihood that you won't have anything that we want to transfer with this cycle. So you may, and the advantage is that without the testing, you may have several embryos that would be transferred, and then you may either not get pregnant, or you may have a miscarriage. Either of those two outcomes delays your beginning another cycle. And you've gotten that much older, which only makes things worse. So they're counseled in the United States, at least at some programs, that it's best to know what you have to work with so that you can move on to the next step more quickly and avoid delays. So if they understand that well, then they're not so alarmed by the idea that it didn't work this time. Of course, it's more money, but it's something that at least they understand that it could happen, and that it doesn't mean you have to stop. It means you try again, and you try again sooner.
Yeah. Well, in Georgia, we have this problem as well, that we are explaining to them that we don't need to transfer lots of embryos to get pregnant. And then we are trying to give them this information about the babies, what can happen. But, what I learned, they cannot hear what they don't want to hear. They just want to become pregnant. And they think that if they are pregnant, even with the twins or triplets, that's okay. They will have these children. But then they don't realize what can happen afterwards, after when child is born prematurely. And with triplets, there are a lot of triplets that just end up being miscarriages
just because there were too
Right.
many.
Yes.
Nothing wrong with the babies. It's just that they deliver early and they can't survive when they're born too soon.
Yes. Well, we have so many, we are so much involved in the future of the families or the babies. So we have to counsel well. We have to make them understand to make a right decision. It has to be part of our job, quite big part of our job, because we know how to work in the lab. We know how to make it well, but then we need their help as well. That's why we are talking about the patient's understanding and knowledge. It's very important, of course. Well, now let's move to PGTA. You mentioned many times PGTA today. And is why they have to consider doing that? Why they have to agree with us to go for it? In Georgia, especially when only one part of Georgia, it's Achara, where it's government pays, completely. The patients are paid for every possible treatment in the territory of Achara. But rest of the Georgia, patients pay out of pocket. So it's kind of hard for them, but why they have to do that?
I think
what you said,
I think that it's important to be confident that the embryo that you're transferring has potential. Mm-hmm. Lots of the embryos that look beautiful from women who are more advanced age, those beautiful embryos just don't have a genetic complement that's going to be appropriate to have them develop all the way to become a live-born baby. So it's good to start with ones that you know have that potential, and the right number of chromosomes is a very gross thing to consider about whether it's got potential or not. But certainly if it doesn't have the right number of chromosomes, that's a pretty clear indication that it is not going to be appropriate to make it to term. So if we can select embryos with the correct number of chromosomes, it improves our success at having a live birth, not just an implantation. Now, it's expensive. But the alternative is to have, for example, a woman who has 5 embryos, one of which it has the right number of chromosomes, but you don't know it, okay? So 5 embryos, one is going to work. It's on average going to be transferred third. Might get transferred fourth or fifth if you do single embryo transfers. And how much is the cost of an embryo transfer procedure? Now, we hear a lot of discussion coming from more Western Europe about add-ons to IVF. And one of the things they consider an add-on is PGTA. They argue, well, why do PGTA if with 5 transfers you'll get the same pregnancy that you would get on the first transfer if you did PGTA? Well, let me tell you, there's a cost to transfers. If you don't know which is the right embryo, each additional transfer that you do is an add-on. No one seems to look at that. They say, oh, well, you just do all the transfers.
Yeah, because, I want to interrupt you in that. In Europe, most of the countries, they cover everything or all the expenses. So government dictates what to do because patient doesn't pay. So why not transfer all of them? So it's a different attitude towards the work.
Right. And the other interesting thing is that in these same countries where they pay for the treatments,
yes,
patients don't continue
there are
to
huge
do
number
all
of
the transfers.
Dropouts. Yes.
They drop out from treatment. Because why? It's not because They can't afford it because it's covered. It's paid for by the government.
Yeah, it's an emotional.
But the government doesn't pay their emotional costs.
Right. Yeah, that's true.
They can't tolerate having a transfer and going through several weeks of waiting and waiting, thinking, oh, well, maybe this time it'll work, maybe it'll work, maybe it'll work, and then just to find out that it didn't work again. They don't want to find out it did not work again, so they won't even bother having the embryos put back. And that's another cost that nobody really considers. Also, transferring of those embryos that don't have the right number of chromosomes can lead to miscarriage.
Not only miscarriage.
Nobody wants a miscarriage. It's a horrible thing to go through.
Or the affected embryo.
Or to have an affected child.
Yes.
So there are advantages to knowing the information, to being able to act with that information. And one of the advantages of using PGTA is that you tend to have live births happen with fewer transfers.
Transfer attempts,
Okay.
right, yeah. Yeah, we cannot really have all the picture what's going on in the embryo, but at least what we know, we can provide it, and we can help them to shorten the time to the pregnancy, right? And to have a healthy baby as well, as much as we can test.
And here at ReproArt, you have your affiliated genomics lab.
Yes.
That can do your PGTA testing for you. So not only is it nearby, but it's also got well-established quality control.
Yes.
Just like we do in our IVF labs. So we have control over the quality of the work that's done and the diagnosis that's done there.
Yeah, and that is the story why we created this lab, you know. I think I told you during COVID time when we were, of course, when we're sending the biopsies to United States, and twice it got stuck somewhere in the middle of the way. For months we were looking for the biopsies. Then we have to reimburse patients. It was so difficult to explain to patients that it's not our fault and nobody's fault, something happened, but for them it was the loss. So we had to...
It's nice.
We had to help them. We had to help them.
It's nice to walk down the street.
Yeah, it's so easy, and that's why I always tell patients I know I respect those labs. They are very good labs, but things like this can happen, and then you have to rebiopsy embryo, which can cause either damage or embryos are not that viable. We can say it's nicely to put that. So we have to thaw them, rebiopsy, freeze them, get the information, then thaw again. So that compromises embryo quality. So that's a good advantage.
When you use a lab that's in the other country, your specimen is being shipped by the same guy that's delivering your toilet paper that you order online.
Yes.
And it gets treated with the same respect.
Right. Correct. Yeah, that's why. That's why it's having it next door. It's just such an advantage. I remember once I was in New York and somebody was saying that, I need to carry our biopsies to New Jersey. I was so angry with them because she put in the car and drove through crossed the bridge, and the embryos were in New Jersey in Cooper. So I was so
envious.
Yeah. Yes. But now we have even closer than across the bridge. That's right. So that's very, very big advantage, of course. Now I want to move to the registry. How patients, actually through the registry, patients should not choose the clinic, but registering data. I was in the United States when they started that business, and I remember how this started, and it was really amazing. And can you give us a brief of the development, and then I will talk about Georgian registry.
There are two major things to mention about the registry. The first is everybody's required to submit their results to the registry, and the registry is validated. The CDC sends people out to make sure that the data that's submitted is correct. Are there patients that had cycles that you didn't report? Used to be that places would publish their results online on their websites. And they would pick and choose what was their best results, only present those. The registry allows you to see results for all age groups and many different kinds of treatments. Okay. I think the second really major thing to mention about the registry is that since it was validated, everybody pretty much reported honestly. And by honestly reporting, it meant the only way to make your results better is by being really more successful. Not just saying that you're more successful, but actually improving your program so that you had better success. The registry in the United States started, I think, long before anybody else's registry, as far as I can recall.
You're right, yes.
And it's really amazing to watch how rapidly success in the United States rose once the registry started. I think people in other countries say, oh, they all lie. They all lie in the United States. It's not true.
I remember that too.
But the fact is, there are people checking to see if you're lying. Now, not everybody gets checked, but eventually everybody gets checked.
So they come and check every...
They select a set of the cycles,
Okay.
usually the ones that look the most suspicious.
Okay.
And now SART actually looks at your results and they go visit people as well. Because of the validation and honest reporting, the success improved in the United States, a lot of countries didn't believe that it was legitimate reporting, but at least you know that somebody's going to come visit you at some point in time. So there's good reason to be honest. I know the programs I've been with, we have always done our best to report honestly. And the result, of course, was this amazing, rapid increase in success of IVF in the United States. At the same time as other countries weren't using a registry and weren't seeing the same kind of success. So I think it really had an amazing effect on causing programs to improve.
Yes.
Because they knew they were going to be compared.
Yeah, you know what I remember when I was already here in Georgia, and there was a study done. They randomly chose United States centers and European centers, and they compared their results, and the United States had twice as good results than in Europe. But now I think they are kind of improving quite, this situation is different, and now they ESHRE won, they got a grant from European Union. It's a 4 million, I think, and they created registry.
Yes.
First for European Union countries, and then they will distribute it to other countries like ours, and we will have possibility to report our data to the European registry. I'm not sure how our country will react on that. We kind of started a registry. We worked very hard on regulations and then on registry as well. There was a group of ITs or the people who worked. Developers. Oh, yes. Thank you. Developers who worked on that. There were lots of problems. There were lots of things to improve, but we were working with them. We were plugging data, and we were all the time in contact with them. But somehow it stopped right now. We don't have register. Of course, when we are now in that phase where everybody is putting on their websites what numbers they want, and nobody really has hand on checking of those numbers. So I hope if we will go from this direction, doing nothing, to that we will start again putting data in the registry, we will improve more. And another thing what I want to mention is that we don't have guidelines. standardized guidelines, but I don't think that there is a real understanding what guidelines are. This is not a mandatory thing. It's just it helps you to guide, not to dictate what to do, right? You cannot have guidelines and protocols which are the same for every center, because every center does things differently, and this all different approach is correct, because this is this kind of field. We cannot standardize everything in different programs. Right now, we are standing on that. We are putting guidelines, but it's really have to be understood. They think our Ministry of Health thinks that we will put the guidelines which they will use to check the centers, how they work. Okay. So this is, and I'm trying to explain that these are these SOPs you need to check if we are doing the way how we wrote that we are doing, and if we are consistent on that, and if we have on place our quality management, quality insurance. So this is but I think at least we are started, so we will go there and we will have better results as you guys.
This kind of gets us into the area of accreditation, laboratory accreditation.
Yes, that's correct.
Which our friend Marina Vaccaria was talking about yesterday at the meeting. And I think it's really interesting to realize that one of the most important things that the accreditation programs insist on is that you have quality management, and that you have a program that you consistently use to make sure everything's working or everything is improving, and they want to see what your program is, or you won't be accredited. So it kind of forces everybody to concentrate on improving. If you have a registry that is honest, means it's because of validation, basically, then the programs are going to compete with each other to honestly be better. And the improvement is the way to do it. Right. So everything fits together with accreditation, a registry. It's all something that benefits the patient.
Right. And it's not about that just to be controlled by someone who has not that even 10% of the knowledge of you, what you have. So we have to create this system and work with that system to really improve everything. It's for our sakes and the patient's sakes as well. So it makes us more safer.
Right.
Let's say.
You have to view it as not an adversarial relationship between you and the government.
Right.
It's really, you both have the same goal in mind.
That's
of improving the product that the patients receive.
Yeah. Well, everything is changing, so I'm sure we will come to the good conclusion. Yeah. And we will work together. And what gives me this, why I am sure that it will happen, how developed IVF in Georgia, how surroundings, how government, how church and everybody is now, I mean, how they feel about IVF. There are so many children born. I think there are no families in Georgia who not have relatives or family members or friends whose babies are born through IVF. So now it is not something which nobody talks about, and they were ashamed of that. But even I remember patients did not say hello to us in the streets because they were afraid that somebody will understand that they are born through IVF. But now it's not that. People are talking openly about that. And this is very important for infertility families to know, families who have infertility, to know that this baby is born through IVF and nothing is wrong there. It's just healthy, beautiful, happy baby. So they can go through the same things. So we are getting much more healthy response, let's say. It's not something, we are not doing something ill. We are just making families happy. So. And it really makes our life much interesting and easier than it was before. Yes. Well, and as we spoke about the systems, what we have to have in our laboratories, one of the main thing is just the safety, how to work and maintain our work safe. What I mean by safe is that, when we put in our lab a witness system and we advertise that we wanted patients to know, and we say that, now we have witnessing system which makes our life easier, and we, of course, still have double witness, but this machine alarms starts alarm if we are making mistakes and we are using someone else's gametes. And the patient wrote to us, until now you are mixing them up. There was a problem with that. Oh yes, it was legitimate question, because patients have no idea what can happen in the lab.
Right.
And then there are not so many publications, and they cannot read about the cases, what happened in the world that with the mix-up of gametes and embryos. And it's not very, very often. I don't want to scare patients, but we don't want to have any in our lab. So, well,
let's back off a little bit, get away from IVF.
Okay.
And let's talk about transfusions.
All right. Yes.
Okay. Transfusions. You get blood from another patient. And there's been a lot of study of how mistakes are made with transfusions. And the common way to avoid mistakes is the nurse that is administering the bag of red blood cells to you, your transfusion, has another nurse check to make sure that it's the right specimen. Okay? So that was done for years. And every now and then, there would be an error that was not caught. And it would oftentimes happen because the head nurse was doing the transfusion, and she would bring the young, new person to the nursing group over to check on her. And the new young person was afraid to say, you did it wrong. Didn't realize that the most important thing in her job was to say, no, don't do it. You're making a mistake. But errors would happen because there's a little bit of bias that gets in there. When you add in a machine, a computer that's doing the identification for you, it doesn't get embarrassed. It lets you know the truth.
So there is no human.
So it helps to reduce errors even further than what the reduction was when two people were doing the identification. So there's an improvement. There's still the chance that nobody uses any checks. And if you forget to check, that's really bad. But as long as the policy that you check and document that you checked at every step, and now that you're using the witness system, you document that you used it, then you're pretty surely not going to have any errors, and it should make the patients feel much more comfortable than they would have without it.
It makes us comfortable as well, Dave.
And it also means you have time to think about what you're doing instead of some of the other stuff. There's more to your life than just identifying specimens. So it makes your lives easier.
There are still things in the lab that you have to have double witnessing anyway. Yes. So it's just, it makes our life much, much easier. And, and patients really... It's really, I think they understood when they coming to the clinic and they are giving card, which has to be put in the machine, and they see that we identify them with the card and they have their labels and so on. And then it makes them more comfortable, I think. But they didn't know that it can be done before. So this is the same thing. You are teaching them, you are giving them knowledge. Yes. To really understand and to feel more confident that they are in the right place. I think so, yeah. And, I think we covered lots of things, right? And it was very interesting. And I always like talking to you, Dave. And we've spent lots of hours talking.
And I enjoy learning from you as well. But it's been many years that we've had these kinds of discussions. So we just didn't necessarily record them before.
Yes, that's true. Yeah, so that's why nice we
let other people share them.
Yeah. So what can be the highlight of this discussion of ours? Like, patients have to remember many things and they have to work with us closely. And if they don't understand, don't be afraid to ask. Please, many times. We are here for that, to help you, It's not easy way to get a child. It's, of course, it involves many things: emotion, finances, time, headaches, and so on, injections, and many, many others. So we are here to explain every step, every moment of the treatment.
And we are very proud of the successes that occur. You guys, when you patients, when you have a success, don't think that you're the only ones that are celebrating.
Yes.
It makes us very proud that we have been able to help you, because that's why we're here. Yes. And as we get better and better at what we do, we're prouder and prouder all the time.
Yes, Dave, thank you. And I want to close this session, and I hope that you learned a lot. And I promise that in the next sessions, we will have more detailed discussion of different topics. Maybe we will ask Dr. Mаккала to be involved from United States as well. We can record him from there as well. Now it's possible. You can be in every place and you can be here as well. So maybe we will have more other discussions with you as well, Dave. Thank you very much for this informative and very interesting conversation with me. So
thank you for inviting me here and for the opportunity to share some of our common interests.
Interests, yes. დიდი მადლობა ყურადღებისთვის. მადლობა სუხდით დოქტორ დევიდ მაკკალას იმისთვის ესეთი საინტერესო საუბრისთვის. ეს ყოველთვის ძალიან საინტერესოა. მე და დევიდ ხშირად გვაქვს ხოლმე ესეთი საუბრები, მაგრამ პირველად ჩავწერეთ დღეს. მინდა გითხრათ, რომ ეს უფრო ზოგადი იყო ჩვენი პირველი პოდკასტი, უფრო გაცნობიტი, გვექნება შემდეგი უფრო დეტალური და მკურნალობის სხვადასხვა საფეხურებს შეეხება. შეგიძლიათ მოგწეროთ და თქვენთვის ყველაზე საინტერესო თემებს დავუთმოთ ჩვენი დრო შემდეგ სერიებში. დიდი მადლობა და ნახვამდის.